from Department of Psychiatry. I am Dr. Swaleha Mujawar. I am the assistant professor here. And today's topic is very, very interesting. We are going to learn about electroconvulsive therapy. So, आप लोगों ने बहुत सारे हॉरर मूवीज में देखा होगा, लोग चिल्लाते रहते हैं, उनको इलेक्ट्रिक शॉक देते हैं. लेट मी टेल यू, ऐसा नहीं होता है, ठीक है. असली में इट इज नॉट how they show in movies or how they show in dramatization. Probably एक shock value के लिए थोड़ा मसाला मिर्च add करने के लिए बताते हैं. And that probably used to happen many years back when there was no anesthesia, when there was no choice. But nowadays it's like any minor OT procedure. So बहुत ही अच्छा procedure है, बहुत effective procedure है. So let's see what we are going to learn. We are going to learn what ECT is, a little bit about the history of ECT, then the mechanism, how it acts, indications, contraindications, what is the whole process of ECT, a summary and then some MCQs. So जिसको भी नींद आ रही है या जो भी jokes बोलना चाहता है, उसी को MCQ सबसे पहले पूछा जाएगा. ठीक है? So what is ECT? So yes, by definition, ECT is an electric shock delivered to the brain. Come, sit. So people who are just settling down, we are learning about ECT today. So yes, like they show in the movies or dramas, yes, electric shock लगा रहे हैं, but as you can see in this diagram here, we are placing two electrodes to the brain, mostly at the temples, and through this electricity goes to the brain, and what happens next we'll see. But basically it's an application of electricity to your brain. It is going deeper into it. It is an artificially induced grand mal seizure. So as you can see here, this is an EEG. So a lot of electrical activity is going on in your brain. So when you apply a very small current for 0.1 to 0.5 second, and that to a current as low as 70 to 130 volts. So after application of a very small current, a lot of electrical activity starts happening inside your brain. And this is what ECT is essentially. So it is an artificial induction of grand mal seizure, which consists of two phases, tonic phase for 10 to 15 seconds and a clonic phase which lasts for only 30 to 60 seconds. And here again it is happening because we are applying the electrical current. So yes, the current is also very small, and the seizure which is happening, that is also for a very small period of time. Now let us go into a little bit history. What is the background of ECT? So in earlier times, researchers noticed that there was a very high density of glial cells in epileptic brains. So patients who were suffering from seizure disorder, patients who were suffering from epilepsy, they had a very high density of glial cells inside the brains, and these glial cells were very less in number in schizophrenic patients. तो उन्होंने दिमाग लगाया कि अगर इसमें कम है और इसमें ज़्यादा है तो let's just add it up and see what happens. So what happened was that they used camphor. Camphor is a chemical. They gave it intramuscularly, and then they induced seizures. So it's an artificially induced seizure in an attempt to replicate the effect of higher glial density cells. So what they wanted was to increase the glial cells inside the brain of psychotic patients. So ECT was first introduced by an Italian psychiatrist, Ugo Serletti and Lucio Beni, in April 1938. After that, a lot of previously used therapies like insulin coma therapy and the chemical induced or the camphor therapy, they were replaced by ECT, because ECT had lesser side effects, it was less painful also for the patient. And insulin coma therapy was introduced by a German psychiatrist, Manfred Sackel. But after ECT came, all the older procedures became obsolete. So this is an ECT machine. We have one in our ward and in our OPD also. So if anybody wants to see. So by late 1930s, chemically induced convulsions were replaced by electrically induced convulsions. And because the treatment involved electricity and convulsions, that's how the name also came into being, that it's a electroconvulsive therapy. So this is a brief summary of the history. 1934, we have pharmacotherapy introduced by someone called as Meduna. After Meduna, then a lot of researches were being done, and they appointed a task force for ECT, and 1976 clear guidelines were given for the use of ECT. So yes, it is a relatively newer procedure, it's an evolving procedure. So what do we do in ECT? ECT is very, very effective, but can have temporary side effects. So that is why people are very skeptical that should we give ECT or not. Then there are ethical consideration, because a lot of psychotic patients don't understand what is happening. So who do we take consent from? We can't give forcefully electroconvulsive therapy. So these are some medical legal issues which come. And also as doctors or as psychiatrists, we don't know exactly what is going on in the brain. So if the relative or the patient asks you, how does this ECT work, or what is going to happen in my brain, what we have is just a hypothesis. So even we don't know what is exactly happening, but we know that patient improves. Types of ECTs you should know. So depending upon the mode of administration, I'll explain this again in the diagram also. So it can be either bilateral or unilateral. If you are giving without anesthesia, it is called as direct or unmodified. We do not give this now. Now we give it with anesthesia. So with anesthesia, it is called as modified ECT or indirect ECT. So what is the whole procedure of ECT? First, again, an anesthetic is given. So depending upon that direct, indirect ECT, then we decide the duration of the current. Then depending upon the duration, it can be either continuous, 0.5 to 1.5 millisecond. In ultra brief pulse, it is less than 0.3 milliseconds. So very, very small period the current is applied. Then if it is unilateral or bilateral. So after this, what we do is, to reduce side effects, the best kind of ECT is an indirect, brief or ultra brief, and unilateral. So this is what is usually the choice of ECT. So in the process of ECT, what we do is, yes, we give a general anesthetic. We also give muscle relaxants, because we are inducing seizures. A lot of time patients can have tonic-clonic convulsions which are very, very severe, so they can have body ache or sometimes fractures or dislocations. So we give general anesthetic, we give a muscle relaxant, then we insert a tongue guard. Tongue guard is inserted again during convulsions. Patient can bite their tongue. So the tongue is not bitten and the teeth are also okay. We insert a very small mouth guard just before applying electrical current. Then electrodes are placed on the scalp, and then the electric current or a shock is given. Usually the seizure lasts for 15 seconds. Now coming to the mechanism of action. So a neurotransmitters theory says that ECT works just like antidepressants. It changes the way brain receptors receive the mood related chemicals. So a lot of chemical processes are happening inside your brain. Whatever chemical processes are changed by the antidepressant, same happens with ECT also. This is a neurotransmitter theory. So not proof, it's just a theory. Anticonvulsant theory says that ECT-induced seizures teach the brain to resist seizures, and this might make the brain stronger or more resistant to stress. Neuroendocrine theory says that when the seizure is occurring, hypothalamus releases a lot of neuropeptides which regulates the mood. Brain damage theory, this has been disproven, but just for theoretical purposes. An illusion that the problems are gone and euphoria, which is frequently observed as a result of brain injury, is just a theory. Psychological theory says that depressed people often feel guilty, and ECT satisfies their need for punishment. Uh, we don't believe in these theories, but as a theoretical, just for knowledge purposes, remember them. Coming to indications, all patients coming to our OPD or in our ward do not get ECT. So how do you decide which patients should be taken for ECT? So these are a few of indications. First indication is severe depression. So depression, when it is so severe that the patient says that I want to end my life, patient is extremely suicidal, this is when we go for ECT. Then schizophrenia, again, mostly severe cases. Mania not improved by medication. Postpartum psychosis, in this period, especially due to breastfeeding, if you're not able to give medications, then ECT is a choice. Schizoaffective disorders, some medical disorders like Parkinson's disease, neuroleptic malignant syndrome also have ECT as a drug of choice or treatment of choice. Also, when we need a rapid response to antidepressants, sometimes, especially if the patient has high suicide risk, patient is not eating, patient refuses medication. So in these also patients, we can't wait for 15 days for the medications to act and then go ahead with treatment. Patient can die during this time. So in these medical emergency conditions, we give ECT. So these are a few indications of ECT. Failure of drug treatment, you are giving medications for 6 months, 10 months, patient is not responding, so then you might have to go for ECT. Patients who are unable to tolerate side effects of drug treatment, like patient has a lot of vomiting or not able to take the medicines. Previous history of good response to ECT. Again, suicidal ideations, don't just think, just suggest ECT to the patient. Severe catatonia, catatonic patients respond very well to ECT. Again, when medications are insufficient, symptoms are severe, so it depends upon your clinical judgment also. But these are a few indications for ECT. Contraindications. When will you not give ECT? One is increased intracranial pressure. So you're applying electrical current to the brain, brain is having a lot of electrical activities, seizures are going on. So if there is already an increased intracranial pressure, damage to the brain can occur, so you should avoid in these patients. Rest of the contraindications are mostly related to anesthesia, like if the patient has coronary artery disease, hypertension, aneurysms, arrhythmias, these can cause problems during anesthesia. Myocardial infarction, especially in the past 3 months, is a contraindication. Then cerebral infarction, that is stroke. Active pulmonary diseases, again, because we are stopping the heart and the lung for a very small period of time when we give general anesthesia. So all these are contraindications. Sometimes just before we give atropine, just after we give muscle relaxants. So if there are contraindications to these, also you might have to stop ECT in the patient. Then again, recent strokes, if the patient is taking barbiturates, again, it can be a problem, especially when the patient has to come out of anesthesia, it causes problem. Some psychological disorders like hysteria, hypochondriasis, we avoid giving ECT. So it's not a contraindication per se, but it should not be given. So patient has been decided for ECT. आपने decide कर लिया अब इसको ECT देना ही है. So what are the pre-treatment things that you should do? One, do a physical investigations, अच्छे से physical examination करो, get a medical history done, get blood and urine tests, chest x-ray is important, ECG, and that the patient should be nil per oral, that is, should not take anything for at least 5 to 6 hours, minimum. Materials required for ECT. One is a ECT team which consists of a psychiatrist, an anesthetist, a psychiatric nurse and some paramedical staff. Then we have the ECT machine, electrodes, the medications which are in a cart. A treatment center should consist of waiting hall for the relatives, a preparation room, a room in which ECT is given, the ECT suite, and we also need a recovery room. Patient might take 2 to 3 hours to recover from the ECT. So recovery room is something where we monitor the patient. And EEG, if it is there, it is good so that we can monitor the electrical activity of the patient. Now, is one single ECT effective? Answer is no. We have to give ECT at least 3 times a week. We can reduce it to twice a week once the symptoms start increasing, but we need to give a lot of sessions. I'll tell how many sessions, but in a week 3 ECTs is okay. If we give more, cognitive problems can occur. So that is why 3 times a week is the maximum limit, twice is better. Coming to electrode placement, so this is a bitemporal placement in which we are placing electrodes at the temples. So what we do is measure from the outer canthus of the eye to the tragus. The midpoint is where you are supposed to apply your electrodes. So it's not very hard and fast that you measure with a scale or something, but just have an approximation, just see where the midpoint is there. There should be no hair, there should be no inflammation at that area, and that is where you apply the electrodes. So this is a bitemporal. In bifrontal, you are applying at the frontal lobe. So this is where you are applying. And bilateral means you are applying both sides. Unilateral is applying just one side. So the second side is spared, only one side the electrodes are applied, and that is also enough in some cases at least. Treatment consists of at least 6 to 12 sessions. So a single ECT is usually not effective, especially in severe cases, and we do give ECT in severe cases only. So 6 to 12 is an approximate amount of session required for depression. For treatment resistant psychosis and mania, sometimes you might need larger number of sessions, almost 20 also. If the patient is catatonia, patient responds very well to ECT. So patient can receive just 3 to 5 treatments also. So depending upon the diagnosis, depending upon the patient, how their response is, we decide the number of sessions, but at least 3 to 4 is the minimum that we need to give. Then yes, before giving actual anesthesia, we give something to decrease the secretions, because during seizures, patient can have a lot of frothing saliva, and that saliva can go in the lungs. You don't want the patient to develop aspiration pneumonia. So we give atropine or we give glycopyrrolate so that all the secretions of the patient are to a minimum or the secretions are not present. This will decrease secretion, will counteract the effect of vagal stimulation induced by ECT. Vagal stimulation leads to parasympathetic overactivity. So that is also balanced by your atropine and glycopyrrolate. So you need not remember the doses, but for people who are interested, atropine is given for 0.6 mg, scoline is your muscle relaxant. It is given 25 to 40 mg, and your general anesthetist, the general anesthetic drug which we use is sodium pentothal, which is given 150 to 250 mg. This is known as a short acting anesthesia because it lasts only for 5 to 10 minutes. Muscle relaxants are given to prevent muscle contraction during the seizure, and it leads to reduction of fracture or dislocation of the bone. Now the role of nurse can be divided into before ECT, during ECT, after ECT. So before ECT, what do you have to do? Check for informed consent. आजकल बहुत cases हो रहे हैं, so medico legally you should be very very safe. Patient should not say कि मुझे ज़बरदस्ती ECT दिया या this was against my will. So always take a written informed consent from the patient or relative. Provide detailed explanation because patients are very anxious, sometimes relatives are anxious. So explain the whole procedure to them, what is going to happen. Patient is kept nil orally. 8 hours is very ideal. So after dinner, you can just tell the patient not to eat anything, not to drink anything. And early morning, we can give anesthesia. So we get at least 8 hours of nil orally. In emergency situations, it can be decreased to 3 to 4 hours also, but try, because we are giving anesthesia. The patient eats something and we give anesthesia, vomiting and aspiration can occur. So patient should be kept NPO as much as possible. Remove metallic articles, so watches, bangles, rings, hair clips, nothing should be there. Everything, especially the metallic things, should be removed from the patient. Also, check for a physical examination, even though you have done it before, just before ECT, a physical examination should be done again. Check for all the investigations which have been done, ECG, blood investigations, whatever. Sometimes patient can have artificial teeth or loose teeth. Always check for teeth. Remove lipstick, nail polish, makeup is not required before ECT. So patient should be clean and having a bath is preferable, and no tight clothes. So, and especially around the neck, there's no need for dupatta. If the patient can have an OT gown, that is the best. But if the patient is in their own clothes, it should be very loose. Then ensure that the bowel bladders are emptied. Oil-free hair should be considered, so a shampoo should be again 1 day before is preferable. Whatever pre-medications like atropine or glycopyrrolate, you can give it. It is given half an hour before ECT so that the secretions dry up during the time. Place the patient on a trolley in the waiting room or in the ECT room, whatever is there. Transfer the patient to a well-padded bed in the dorsal position. Again, reassure the patient. Uh, the anesthetist administers the muscle relaxant and the general anesthesia. Verify the dose always, and a mouth gag should always be placed. Now during ECT, so you have done all this, the doctor is ready to apply the current or the electrical shock. Support the shoulders and arms. If the patient has violent seizures, just make sure that you lightly touch the shoulders or wherever there's a lot of seizure activity going on. Hyperextended head with support to the chin. This is again to prevent any aspiration, to prevent tongue fall, because even if the tongue falls back, oxygen might not go to the lungs. So a hyperextended head with chin support, oxygen is given usually through a mask, 100% oxygen. Electrodes, once it is there, it should be dipped in saline or jelly. See that a proper generalized tonic-clonic convulsion comes. After the patient has had seizure activity, suction should be done, especially if there is, I know glycopyrrolate prevents secretions, but some patients do have a lot of secretions in spite of that. So try to do suction if you see any secretions there. If the patient is not able to breathe, you can place an airway inside, give oxygen and prevent complications. After ECT, observe for vitals. So you check saturation, pulse, blood pressure. These are the things which should be monitored. put up the railings, patient can be very drowsy or confused, patient can fall down. So safety of the patient is most important. Place in a lateral position, because again in lateral position, if the secretions are there, they'll flow down the mouth and they won't go inside the lungs. If you see some secretions, wipe it, no need to do suction. It irritates the patient if the patient is conscious and if you're doing suction. Again, record the vitals, BP, for how long the patient has loss of consciousness. And once the patient is stable, you can check the vitals and everything for every 30 minutes till the patient has full recovery. If the patient wants to sleep, patient can sleep, no problem. Reorient the patient to ward. Like I said, patient is very confused after the seizure. If there are some injuries, if the patient is complaining of some pain in shoulder or pain in the back, record it, inform it, keep the unit tidy. So after ECT is done, what are the side effects which you see for? Most common side effect is dizziness, dryness of mouth, because we are giving things which will decrease secretion, headache, muscle pain, nausea, vomiting, jaw pain. These usually don't occur if we give a good muscle relaxant. Sometimes patient can have unsteady gait, poor concentration, anxiety, incontinence can also occur. If you are not placing the tongue guard properly, tongue bite can occur. Cardiac arrest, delirium. A very commonly seen side effect is memory impairment. So patient says that I am not able to remember what I ate for breakfast or what I ate last night, but it is not permanent. It is a temporary memory impairment. So memory will come back to normal once the patient recovers from ECT. Sometimes hepatic function can be decreased. Very rarely medical complications like heart problems, death or other side effects related to anesthesia can occur, but it's quite rare, it's not very common. So just to summarize, let's just go through whatever we have read. ECT is production of an epileptiform convulsion which can last anything from 30 to 80 seconds. Modified ECT is given, so that is with anesthesia, with muscle relaxant. We are passing a very small amount of current for a very small duration of time. Then we can give bilateral ECT or unilateral ECT. The number of sessions also vary. Usually it is given 3 times a week. In depressed patients, 6 to 12 treatments, schizophrenics and mania patient might need more. Reassess the patient in between treatment and stop when there is no improvement. Don't be very over enthusiastic. If you see that the patient is not responding to treatment, you can stop it also. Some of the side effects can be cardiac, memory, headache, prolonged seizures, side effects of anesthesia which you will learn in anesthesia classes. Contraindications are again recent MI, raised intracranial pressure, stroke, relative contraindications like fever, arrhythmias, hypertension, these can occur. Mortality is very less, between 1 in 1000 or 1 in 10,000 also. Now coming to the MCQs. So I have told this before. Which of the following conditions is known to have the best response to ECT, or what condition will you definitely say that ECT should be given? Good. So everybody was paying attention. Good, I'm happy. The commonest side effect of ECT is? No. Amnesia is loss of memory. Okay, dementia is a cognitive impairment. उसमें भी loss of memory होता है. This was just to confuse you guys. But remember, amnesia. So whenever you will get MCQs in your exams, don't be in a hurry to answer. अच्छे से पूरा पढ़ो, एक्सेप्ट लिखा है, कॉमनेस्ट है, लीस्ट कॉमन है, क्या है, just because we'll always give you two options which are very similar just to confuse you. So what is true about electroconvulsive therapy? It is contraindicated in brain tumors. It requires 70 volts. Treatment for major depression. Very good. So the answer is all of the above. Advantages of unilateral ECT. That it is more effective, more preferable, less number of treatments, or less confusion, amnesia, and other side effects. Just apply common sense that see, if we're giving unilateral, the amount of current is less. So it is less confusion. So it is not more effective, it is less effective, but the side effects are also less. So if you feel that the patient can have side effects, then you should prefer unilateral. But if the patient is very severe, you need good effects, then bilateral should be preferred. This is a rote learning question, and if you were paying a lot of attention, then only you'll get. This is a difficult question. So the first use of convulsive therapy for the treatment of psychiatric disorder was by Meduna Bennett, Igaz Moniz, or Kurt Schneider. No, no. Igaz Moniz is your neurosurgery. So he did temporal lobectomy. Some of you are correct. So one Meduna. This was there in the lecture. I know history is a very boring topic, and it's okay. At least you've understood the procedure of ECT and you've grasped what it is. At least a general idea of ECT. This I think everybody should be able to answer. The sequence of administration of medications. So how will you administer medications? Atropine, thiopentane, pentone and succinylcholine. Then scoline, atropine, thiopentone, etracorium, it was not there. The confusion should be between A and D. Because we don't give muscle relaxant the first time. A is the answer. So yes, very good. So most of you were listening. I'm very happy. So with this, we end the lecture. Thank you so much for listening. Any questions, any doubts that you have?